Good afternoon, everyone.
Good afternoon po, Doc.
Are you complete? All right. Can we start?
Yes po, Doc.
Okay, for a while. Let me share my screen. Um, okay. Can you see the slide?
Yes po.
Ito.
All right. So today is just an online class, but our topic is a continuation of the connective tissue diseases. All right. So last meeting we started discussing the prototype of all your connective tissue diseases, which is your systemic lupus erythematosus. Now let's move on to discuss some of the less common connective tissue diseases. So this is the part one. So for this part, we'll only discuss your systemic sclerosis and Sjogren's syndrome. Okay, so this will be our objectives. As you can see, we have several other rarer connective tissue diseases. You have systemic sclerosis, your Sjogren's syndrome, you have your inflammatory myopathies, and your mixed connective tissue disease. But for this meeting, we'll just discuss on the two, and then on next meeting, we'll discuss the other two. So let's start with systemic sclerosis. Systemic sclerosis is an orphan disease of unknown origin. So
Hello po.
hello.
Hello po.
Yes po, Doc.
Sorry for the interruption. I just got disconnected and there has been a power interruption in my condo. So I'm just using my mobile data right now. Okay, for a while. There you go. Can you see the slides?
Yes po, Doc.
Opo.
Okay, so just tell me if just tell me if it's a little bit slow or probably choppy. All right, because I'm using a data. I'll just turn off my video to just lessen the bandwidth allocation. Okay, so as I was saying, this is an orphan disease of unknown origin with complex pathogenesis and variable clinical presentations, just like your lupus. So once you have systemic sclerosis, it will follow a progressive course. So it's like a rabbit hole. So once you start having the symptoms, the target organ damage is inevitable until there will be an organ failure. And this will cause significant disability and mortality. Again, it is sporadic and there will always be a female predominance with a ratio of female to male in about 4.6. That's about 5 to 1 female to male ratio. And again, same as your lupus, it is pronounced in the childbearing age, owing to the contributions of your chromosome X and your hormones. Okay, but it also declines at menopause. Just like lupus, blacks and have higher incidence and higher mortality rate. So again, the virtually all every organ is affected in systemic sclerosis. So remember, systemic all organs, sclerosis. What do you know about sclerosis? Anyone? Hello? Anyone? Are you still there?
Opo, Doc.
Huh? I can't hear you. Are you still there?
Yes po, Doc. Yes po,
You
Doc.
you respond because I can only see my slide. I cannot see you. So there's no point of me talking here. If I couldn't see you and I'm not sure if you're listening or not. I'm just gonna be wasting my voice, right?
Opo.
Or or better yet, I'm going to require you to turn on all your videos. Okay. So, when you hear of sclerosis, what do you think?
Stiffening or hardening of any tissues.
Okay, so it's hardening of the any tissue for that matter. So it can be the skin, it can be the internal organ. So what happens if your organs are sclerosed? Meaning to say, let's say for example, if your lungs is sclerosed, that's good as fibrosis. So it will not be able to expand, it will not be able to function, it will not be able to accommodate the air that comes into the lungs. Same goes with your heart. If it's sclerosed, then it will not be able to function. The it can will not be able to carry on the cardiac cycle. Okay, so that's the clinical implication of an sclerosis. And remember, in systemic sclerosis, it involves all of the organs. Okay? So, for the etiopathogenesis, again, always been mentioning this, especially in your RA and in your lupus, genetic susceptibility is important so that once you are able to be exposed in an environmental factors such as maybe infection, drugs, or any other agents, then that can contribute to the development of inflammation. Okay, so note that there has already been an interplay of these three, and so once you have that, genes just like the ones that are flashed on the screen, these are your genes. It can be from HLA or origin, and your infectious or environmental exposures can be from infectious agents, may be viral. Most of them are actually viral. And then environmental exposure, especially the ones in the occupational exposures, diets, drug, and even radiation. Okay, so we also have special consideration to epigenetic dysregulation wherein there is uh, an alteration in your post translation of your DNA in your histone acetylation and also DNA methylation. So when you say epigenetic dysregulation, there is a change in your there is a change in your what do you call this, in your DNA translation, but it does not actually change the genetic code. Okay? So that's your epigenetic dysregulation. So all these three would cause inflammation. So once there is an inflammation, as you can see in the image, inflammation, there will be fibrosis, vasculopathy, or autoimmunity. So autoimmunity given by the fact that there has been a presence of your autoantibodies, right? So that's part of your genetics. Now, if there is an increase in inflammation in the body, as you can see in the arrows, it's bidirectional. It's not actually bidirectional, or yeah, it's bidirectional because, for example, you have inflammation, and then this inflammation would actually cause vasculopathy. When you say vasculopathy, any injury of your endothelium or your vascular injury. So it will destroy the epithelium, the anatomic structure of your vessels, thereby leading to probably cell recruitment, fibrosis. Okay? So as you can see in the arrow, the inflammation would cause vasculopathy. But remember that once you have vasculopathy, it can cause further inflammation. That's why the arrow is bidirectional. Same goes with fibrosis. The fibrosis will actually cause further inflammation. But on the other hand, or to begin with, inflammation actually causes the fibrosis. Okay? So once you have vascular injury, it will cause fibrosis of the organ that the vessel is actually supplying with blood, since there is vascular injury. But once fibrosis starts to develop, it will cause further vasculopathy in the surrounding structure. Did you get that? Did you get the edge of pathogenesis of sclerosis? So
Opo.
remember, you have an interplay of your genetic factors, your environment, epigenetic dysregulation. All of these can cause inflammation, vasculopathy, autoimmunity, and fibrosis. And either in either way, it can cause these problems. And so it will go on until there will be a target organ damage. Any question with etiopathogenesis?
None po
Opo.
daw.
Did you understand this? Okay. So here is another better explanation for all the things that I mentioned in the last slide. Okay? The image on your left is lifted from my textbook. That's how uh, it was put in a diagram. But in the algorithm lifted from Harrison's, this has a better explanation. So it's a good read. I'm not really requiring you to memorize everything, especially those inflammatory cells. But what you have to know is that, let's start with vascular injury. Okay? Once you have vascular injury, a destruction in the endothelium, it will actually cause you microangiopathy that makes your uh, vessel permeable to any agent. It can cause proliferation, probably thrombosis, or right? So this cause actually tissue hypoxia. Once you have tissue hypoxia, it will cause fibrosis. Okay? I'm not sure why is there no arrow in my slide. For let me see. It's moving. But can you follow can you read the fibrotic cellular response?
Opo.
Yes. Okay. The one in the middle. So the fibrotic cellular response is brought about by tissue hypoxia from your microangiopathy brought about by your vascular injury. But remember that once you have fibrotic cellular response, such as proliferation of these cells, it will cause further microangiopathy. Can you appreciate the bidirectional that I've been mentioning earlier? Hello.
Opo daw.
Okay. So I want you to read on this. So I think I've explained it properly, but for your further reading, you read on this diagram. I think you can get a lot from this diagram alone. Is that clear? So we can move on. So let's say you go to your autoantibodies, the one in the right side of the algorithm. So the presence of anti-centromere, anti-topoisomerase 1, anti-RNA polymerase 3, your anti-receptor antibody. These are the antibodies of systemic sclerosis. So remember in SLE, what are the antibodies? ANA, anti-dsDNA, and so on. Right? I think in the diagram in your last lecture, you also saw anti-centromere and anti-topoisomerase and also your RNA polymerase. These autoantibodies is highly specific for systemic sclerosis, but they can also be present in your systemic lupus erythematosus because sclerosis can be a symptom of your lupus. If that happens, then they can be overlapping conditions. Is that clear?
Opo daw.
Okay, so let's move on. If this is clear to you, always remember this diagram. Now, for systemic sclerosis, there are several subsets. As you can see on the first diagram of a human, it's free of color blue. The color blue represents your sclerosing. Okay, the hardening of the skin. So, you call this early or sine scleroderma. Okay, or scleroderma, sine scleroderma. Okay? So, this scleroderma is a type of systemic sclerosis that do not present with any skin manifestation, but it has hardening or fibrosis of the internal organs. So, if a young woman presents with interstitial lung disease or hardening of your fibrosis of your lungs, or even fibrosis of your heart that is presented with by pulmonary arterial hypertension or sudden chronic kidney disease because of fibrosis of the kidneys, then you consider that as sine scleroderma or scleroderma sine scleroderma. For type 1, it's limited. Okay? It does not extend to your wrist, it does not extend to your ankle. Is that clear? But also affects your face. For type 2, it's actually it actually involves your peripheral extremities, but extends to your elbows and to your knees. Okay, it also affects your face. But for diffuse, it actually involves all over the body. So you have to remember the clinical subsets of systemic sclerosis depending on the involvement of the skin. Now go to the right table. For systemic sclerosis, actually it can be for sclerosis or scleroderma, for that matter, it can be localized or systemic. When you say localized, it only affects the skin. Okay? But for systemic, it also involves your internal organs. But for this lecture in Rheuma side, we only discuss systemic sclerosis. Why? Because localized scleroderma is managed by our derma counterparts. Okay? But once these scleroderma patients develop involvement of the internal organs, then they will be referred to um, rheumatology. Understood?
Opo.
Just like your lupus, we have cutaneous lupus and we have systemic lupus, right? For cutaneous lupus, it's only the skin. But for systemic lupus, it involves other organs. Same goes with systemic sclerosis. So we've discussed the limited and diffuse, the image that is shown in the left side. There are also overlap syndromes which will be discussed in the next meetings, okay? We have mixed connective tissue disease and polymyositis scleroderma overlap. So these conditions are actually just an overlap of several autoimmune illnesses. They present with sclerosis, okay? Here are the other subsets that I've been mentioning. We have your scleroderma, sine scleroderma. For the exam question, patient presents with fibrosis of the lungs, fibrosis of the kidney, fibrosis of the heart, but they did not present any skin hardening. So that's scleroderma, sine scleroderma. You also have other condition which is your CREST syndrome. It's a syndrome that is collective or composite of calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasia. All of these will actually present with skin hardening or sclerodactyly. Okay, so that is considered as clinical subset of systemic sclerosis. So what's the first point? Do you have question?
None po.
None? Okay. So let's go to the clinical features. As I mentioned, there are systemic features. And here are the different uh, different features. So virtually all organ are affected, and later on we will discuss probably one by one. Here are the skin manifestations that is very important in systemic sclerosis that you need to identify, because if you see this, then probably think of scleroderma. So first we have your Raynaud's phenomenon. I hope you're familiar with Raynaud's phenomenon. It's a discoloration of your skin depending on the temperature change. Okay? You also have digital sclerosis, ulceration because of hypoxia from microangiopathy. Okay? As, we'll discuss the other skin manifestations first. We have your hair loss. It's because oxygen or nutrients does not provide anymore to your hair follicles. Second is sclerodactyly. Okay? Contractures plus hardening of your skin. Hyperpigmentations, as you can see in the middle photo, it can be prominent over the anterior surface of the chest. We have skin thickening. This is how you measure skin thickening. It's a Rodnan scoring. I hope dermatology has discussed that to you. So you just pinch, you measure if it goes back slowly or it feels hard to pinch. No, and then you also have salt and pepper appearance. The lowest photo is your telangiectasia. It's because of microangiopathy as well. Now, nail nail fold capillaroscopy is actually imaging. It's not actually imaging. It's like, yeah, probably you consider that as imaging. But
Doc, we can't hear you.
because there is hello, can you hear me now?
Yes po.
Sorry, the electric power just came back, so it moved to the Wi-Fi signal for a while. I'm going to share again. So where did we end?
You were explaining the pictures.
The capillaroscopy.
Yes po, Doc.
Okay, so let's go back to the capillaroscopy. How do I use the pointer? I cannot use the pointer while I'm using the presentation. Do you happen to know how um to turn on the pointer here on Keynote? None.
No po.
So okay, sige. Let's just proceed. So going back, so we're talking about capillaroscopy, right? The one on the right upper corner photo. So this represents the capillaries in your nail beds. Okay? Why is it important to assess this? Because it represents microangiopathy. So it is a good measure on considering an internal organ involvement. Is that clear? So you can use, there is a capillaroscope that is especially used for capillaroscopy, but you can use ophthalmoscope to view the nail beds. Okay? Sometimes, if you have systemic sclerosis, it's very prominent. So the photo in the first photo, okay, can you see the very well-defined vessels? Can you appreciate that? The first photo? Uh, can you see it? Because I don't have pointer.
Yes po.
Okay. So the first photo actually represents very well-defined vessels, okay? It has a relatively similar architecture from each other. But on the far right, on the next photo, you can see tortuous vessels, right? It's dilated because the the pathogenesis of microangiopathy is starting, okay? Until the vessels would actually rupture. So if you can see in the left lower photo of the normal lower to your normal photo, the most of the vessels are actually dilated. Okay, so once it is dilated, it causes hypoxia, it causes now your further inflammation, it causes now cellular injury, target organ damage. Now, what's the response of the body to hypoxia? It will form new vessels. So as you can see in the lower right, there are new vessels, there is new neovascularization, but it did not follow the architecture of the normal. Okay? Did you appreciate the photo? The
Opo.
vessels?
Opo.
So that is what's going to happen once you have microangiopathy. Okay? So nail fold capillaroscopy is part of the assessment or in your physical examination if you have systemic sclerosis, because this represents severity of the conditions. So if you have this, then most likely internal organs will actually follow. Okay? Clear? So let's start with the gastrointestinal. The most common for gastrointestinal, just listen to me. Since there is fibrosis, there is hardening of the alimentary tract, what will happen? It will not be able to perform your peristalsis. Remember that you have your circular and longitudinal muscles there, continuously doing its involuntary contraction. Correct? So, if you have fibrosis, it will not be able to function properly. And so, the symptoms, as you can see, here in the principal manifestation will happen. So the most common among all of these would actually be dysphagia. So sometimes patients would actually complain of dysphagia. Okay, it can be a first manifestation of all this, the systemic symptoms. Okay, question: dysphagia is the most common, but other conditions can occur. Clear for gastrointestinal?
Opo.
Okay, let's move on to pulmonary. This is more important because this is the most common presentation. So again, I mentioned earlier that for once it becomes hardened or fibrotic, it will cause hardening of your um, pleura or your lungs. Okay, as you can see in the CT scan image on your left, you have your NSIP and UIP. These are the two patterns of interstitial lung disease. You have non-specific, meaning to say it can occur any part of the lungs. But for usual interstitial pneumonitis, that is your diffuse. It can occur all over the lung at one point in time. Okay, so for non-specific interstitial pneumonitis, some part of the lungs are affected, but for usual interstitial pneumonitis, um, it occurs all over the lungs. And UIP is the most common pattern in interstitial lung disease secondary to systemic sclerosis. Okay, I think that is also true to your SLE and RA. Now, these two conditions, your interstitial lung disease and pulmonary hypertension, presents as DOB, easy fatigability. Okay, but for pulmonary hypertension, it presents with chest pain and cyanosis. So we have risks for this. For interstitial lung disease, diffuse type of systemic sclerosis is the most common cause. But for pulmonary hypertension, it's usually limited skin disease. All right, that's type 1. And they have corresponding autoantibodies present that are risk factors for developing interstitial ILD and PAH. Okay? So, how do you screen these patients? You can see, as you can see there, the screening is, so let's say a patient is already diagnosed with systemic sclerosis, develop difficulty of breathing, easy fatigability, then your screening technique would be your HRCT or high resolution chest CT scan and also 6-minute walk test. That's your screening. Once you screen the patient to have this pattern or probably failed on a 6-minute walk test, then you need to do pulmonary function test. That's your confirmatory. Okay? So you ask the patient to do a pulmonary function test. The forced vital capacity and total lung capacity is actually reduced and it shows a restrictive pattern, and also the diffusing capacity of the capacity of the lungs to diffuse carbon monoxide or your DLCO is also decreased. Okay, so that's how you confirm your ILD. But for pulmonary hypertension, once you do PFT and they have exertional dyspnea, fatigue, normal normal FBC and TLC are seen on pulmonary function tests, but they also have reduced DLCO. All right. So how do you confirm presence of pulmonary arterial hypertension? Remember that the gold standard would still be right heart catheterization. Once you request 2D echo with Doppler, you will only see an elevated pulmonary artery pressure, but that does not confirm the presence of pulmonary arterial hypertension. Is that clear? Clear for pulmonary manifestation?
Opo.
Yes, Doc.
Remember
Yes po, Doc.
this. Later, we discuss the treatment. For now, let's discuss the clinical features first. Again, cardiac. No need to memorize everything. Remember that the cardiac muscles are replaced by your myofibroblasts. And these myofibroblasts will cause proliferation and cause fibrosis. Okay? Now, if you have lesser cardiomyocyte and these are outnumbered by your myofibrils, then probably or myofibroblast, and there is a proliferation in your interstitium, then it will not be able to pump properly. So it will cause fibrosis, then leading to these conditions. So conduction defects, hypertension probably, heart failure, coronary artery disease, spasm, and pericarditis is rare. Remember, pericarditis is common in RA. Okay? So just read on the epidemiology and poor prognosticators. Clear? Clear with cardiac? So we can move on to renal. Again, renal. Again, it will cause scleroderma renal crisis. So, same as your heart, same as your lung, there is an interstitial fibrosis causing now chronic vasculopathy. So if there's chronic vasculopathy, what happens? It will cause hypertension, or it will cause, imbalance between the functions of your afferent and efferent arteriole, causing now hypertension, or hypoxemia for that matter, leading to what? Deposition of your inflammatory cells. Unlike in your lupus, the problem in lupus is, recall what? What's the problem in lupus nephritis?
Fibrosis.
Not fibrosis. Fibrosis happens in your scleroderma renal crisis. In lupus nephritis, always remember this. I've shown you the international society classification. It depends on the deposition of your immune complexes that destroys your glomerulus. So that's why the destruction of your glomerulus is measured, so that they will be classified into class 1, class 2, class 3, and class 4 and class 5 up to class 6. Is that clear? But for this condition, specifically, there is chronic vasculopathy. Clear?
Yes
So,
po.
Okay. What you have to remember here is that it's in the box. Corticosteroid use. We cannot, actually, in the books, they mention that using moderate to high dose of steroids can cause actually scleroderma renal crisis. But in real practice, we shy away from using this even in at the lowest dose possible. So be careful in using steroid in these patients. Okay, so not all autoimmune can actually receive steroid. Is that clear? This is the best example. Because once you start corticosteroid therapy in the form of prednisone, hydrocortisone, it will actually cause further injury to your kidneys. Is that clear?
yes po.
Do not start steroid in this patient. MSK, again, inflammatory arthritis. The difference of SLE and RA is that the erosion, right? In systemic sclerosis, it is erosive. As you can see, there is an erosion. Same as your RA. Okay? And the hallmark of severe scleroderma is your joint contractures. Once you have joint contractures, you call that sclerodactyly. Remember that, sclerodactyly, very important manifestation. Okay, with musculoskeletal, I don't think uh, I need to explain further the inflammatory arthritis because I know you already memorized that. Can we move on to the next slide?
Opo, opo.
Po daw.
Okay, so these are the associations review. And others, there can be symptoms from manifestations from your endocrine, your neurologic, bone disease, but relatively lesser common. So, but just familiarize yourselves with these manifestations as systemic sclerosis is systemic. Okay, so going back to the symptoms, this is how you diagnose your systemic sclerosis. Based on the American College of Rheumatology or European League of Associations for Rheumatology, the highest bearing score would be your skin thickening, bilateral, fingers extending to proximal to MCP. Remember the type 1 limited up to the wrist, right? Should be up to that point, at least. Because if you have that at least, the score is already 9. And mind you, to diagnose systemic sclerosis, you should meet at least 9 points. So if you already have skin thickening, you really don't need the other symptoms. Is that clear?
Yes, yes.
Opo daw.
Okay, but aside from sclerodactyly, sometimes it occurs in the early phases. You have puffy fingers. Look at your hands. If you have puffy hands, you have been experiencing inflammatory arthritis, then consider systemic sclerosis. Okay? And more severe conditions, internal organ manifestations, you have your presence of autoantibodies and also digital ulcerations. Clear? Remember, you can also have your telangiectasia and abnormal nail fold capillary pattern, the one that I've seen. I've shown you earlier, the nail fold capillaries. Okay? Clear? That's how you diagnose your systemic sclerosis. Okay, going back to the treatment, you know what? Actually, the problem with systemic sclerosis, once you have that, actually, um, once you, it's like a rabbit hole. Once you started having scleroderma or fibrosis, then the condition is already progressive. Okay, what you have to do is just use these medications to treat the symptoms, the current symptoms, but not actually preventing the patient from having adverse complications. The patient will just die in the future, but these conditions will just prolong their lifespan. Understood? So you have your immunosuppression here in the form of cyclophosphamide, mycophenolate mofetil. Again, it depends on specific organ manifestations. So if you have interstitial lung disease, if you have uh, renal involvement, then cyclophosphamide and mycophenolate mofetil is your drug of choice. Just like the ones you use in lupus nephritis and ILD in RA and lupus, right? So the others, methotrexate and azathioprine, can only be used in arthritis and consider other biologics. But up to this point, it's not yet well studied. And I think if there is an improvement, it's very minimal. It's less than 5% in 1 year. Okay, is that clear? Any question? We have here newer drug. I think pulmonaris, pulmo would actually discuss this to you. You have your nintedanib and uh, pirafidone. It's a relatively newer drug. It just came out a year or two ago. And during my training, it's actually drug used in clinical trials only. But the result is actually very low. It's the basis of the less than 5% improvement in 1 year. But some case reports would tell otherwise. Some patients actually improved. So we don't know yet. But if they can afford this medication, then why not? I think the one tablet is needed or two tablets per day, and you have to, it costs actually around 5,000 per day. Pesos. That's in pesos. Okay, so it's expensive. And then the improvement is very minimal. Any questions with the treatment? This is how you treat for immunosuppression. And on this table, this is how you manage the specific symptoms. Not to treat, but actually supportive treatment. So let's say if you have a Raynaud's phenomenon, you can use phosphodiesterase 5 inhibitors. What are phosphodiesterase inhibitors? What type of medication?
Sildenafil.
Sildenafil, your Viagra. Okay, so you use that for Raynaud's phenomenon. And also, if you have hypertensive renal crisis, then you can use calcium channel blockers, ARBs. If you have GI involvement, you just use prokinetics and the rest. Just read on this one. Okay? Remember, it will not treat systemic sclerosis. It will just support the symptoms. Question? Any question?
None po to.
Okay, so the survival, always remember this, slight improvement of 5-year survival rate for diffuse scleroderma, 75% of deaths directly due to the disease manifestation. So you will not die of scleroderma, but you will die of acute respiratory failure from your ILD, or probably cardiogenic shock from coronary artery disease, or from arrhythmia. Okay? Poor prognosticators are on the box. But if you have cardiac involvement, you only have 5 years to live. And we tell that to patients. Okay? Any question? Question? None?
None po, Doc.
Okay, so that's systemic sclerosis. Always remember systemic sclerosis. It's also one of the favorite questions in the board exam. Okay, because for it is actually the second most common. It is not really second most, but it's relatively common next to SLE. Okay, so can we move on to our next topic? Your what do you call this? Your Sjogren syndrome. Okay, so Sjogren syndrome is an autoimmune disease characterized by your lymphocytic infiltration of your exocrine glands. What are your exocrine glands? Name it. What are your exocrine glands? You have to know exocrine
Salivary.
glands. Okay, what?
Salivary.
Sweat gland. Sweat.
Okay. And your lacrimal gland. So, the main problem is infiltration of lymphocytes in your exocrine glands, thereby causing now xerostomia. What's xerostomia?
Dry mouth.
Okay, what's keratoconjunctivitis, Sika? What's Sika?
Dry eye disease.
Okay. So since you have a problem in your exocrine glands, it causes now dry mouth and dry eyes. Aside from that, there is a relatively high activity of your B cells, and later on we'll talk about that. So it presents with wide clinical spectrum and organ specific to systemic disease. But what do you know about xerostomia and Zika? From our previous lectures, these are common symptoms or manifestations of your autoimmune illnesses, right? You have your rheumatoid arthritis, your SLE, even systemic sclerosis would actually cause xerostomia. I just failed to mention, but you can see it on the table that I mentioned earlier for your reading assignments. Xerostomia is actually one, and Zika is actually one. Okay? So the clinical implication is that the symptoms of Sjogren's syndrome can actually be a symptom of your other autoimmune illnesses. So a Sjogren's syndrome is relatively underdiagnosed because it can be a part of an existing autoimmune illness. So the association for RA, limited scleroderma, and SLE is very high. Okay? So if you have RA, if you have SLE, and you have Sjogren's, then you call this secondary Sjogren's syndrome because it's just the manifestation of a bigger systemic disease. Is that clear? So the prevalence is actually 0.5 to 1%. Female predominance, the female to male ratio is 10 to 20 to 1. And it can occur at any age. So earlier disease, it can be aggressive. And Zika symptoms are seen in 5 to 20% of all your autoimmune illnesses. And here, there is a high probability of lymphoma development owing to the B cell activity. Any question up to this point? Any question? Clear with, are you clear with Sjogren syndrome definition?
Yes po.
Mm-mm. So the etiopathogenesis again. We always talk about gene association, about environmental association, and these are the genes involved in development of your um, in the development of your Sjogren syndrome. You also have viral agents. You have your hormones. You have stress. Okay, you have ac- um, your anti-Rho and anti-La. Okay, autoantibody. So, this will actually heighten the antigen presentation. So once these factors are presented to your T cells, what will happen? Same as your RA, there will be a differentiation of your T cells to T helper, cytotoxic, memory cells. Okay, but the thing with Sjogren's syndrome is that the the activator, this one buff, as you can see there, this is the B cell activator. Okay, so this B cell activator is heightened. That's why B cells are overactive. If overactive, then it will promote plasma cell production of your autoantibodies and immune complexes. Is that clear? That's why um, that's why your B lymphocyte hyperactivity can cause further inflammation. Okay, so for other pathogenesis, lymphocytic infiltration of exocrine glands, especially your salivary and lacrimal glands, occur because of the interplay of your genes and other factors. Any question up to this point? If none, remember that lymphoma is also common in Sjogren's syndrome, owing to the fact that interleukin 18 is one of the key inflammatory cells in the etiopathogenesis. Okay? So lymphoma should be worked up for all patients that are diagnosed with Sjogren's syndrome. Now, let's move on to your clinical features. We've been mentioning there is dry eyes and dry mouth. So once you have dry eyes, then once you have dry mouth, serostomia, there will be difficulty swallowing dry food. Okay, there will be burning sensation, probably because of sloughing of your mucosal lining. Also, because of dryness, it becomes erythematous. There will be atrophy of your filiform papillae. There will be lesser saliva, and there will be parotid enlargement because of hyperreactivity. So, how do you measure serostomia? You just don't say, "Oh, I have a dry mouth." Okay, so you have to quantify the dryness of the mouth or saliva for that matter. So you do sialometry, or probably you do imaging using ultrasound, MRI, or MRS. You even do biopsy of your glands to check for lymphocytic infiltration and B cell activity. Is that clear?
Yes po.
Okay, so you measure saliva. These are the methods on how you measure your saliva. Sialometry is the gold standard. Next is Zika, your keratoconjunctivitis Zika. Remember that if you lack, have you experienced dryness of your eyes? It seems to you seem to be having dry eyes because of lack of lubrications. Once you study for a long time, or even awake the whole night, do you feel that? It's very dry, it's sandy, there's a sensation. Why? Because there's no lubrication. You need lubrication, especially when there is a persistent opening and closing of your eyelids. Okay? It becomes it there will be burning sensation. Okay? And in the long run, it will cause how do I say this? Scratching of your um it's keratitis. You know keratitis, right? There will be scratching of your cornea. Is that right? So once you check the patient on sleep lamp using your Lisamin green or rose Bengal stain, you will appreciate dryness and scratching of the linings of your eye. And then Schirmer's test is used to measure the tears. It quantifies the tears. So I think just read on how it's done. I don't remember specifically, but you put the paper and then you expect a certain length should be wet in application of this shear of the paper. Is that clear? So once you have xerostomia and keratoconjunctivitis sicca, this is part of the triad for Sjogren syndrome. What's the other one? Any guess? What's the triad for Sjogren's? You have xerostomia, you have Zika or keratoconjunctivitis Zika. What's the other one?
SL.
Hmm? What?
Lymphoma.
No. It's on the
Okay.
others. Guess. Any guess?
Arthritis.
Arthritis. Okay? If you have xerostomia, you have keratoconjunctivitis Zika, you have arthritis, think of Sjogren's syndrome. Okay? So the others, all of them is brought about by dryness. You know, if you have dyspareunia, then probably the vaginal mucosa is dry. If you have serotrachea, I don't know how that feels, but I think the trachea is non-lubricated. You also have dry skin. What else is there to memorize here in the clinical features? Yeah, there. For immune complex mediated, if this is the problem, then you'd have a problem in your kidneys, such as membranoproliferative glomerulonephritis. Okay, your MPGN. Now, vasculitis is also common manifestation in Sjogren's or the other way around. If you have vasculitis, you can have xerostomia or Zika, just like SLE. Is that clear? So lymphoma has a higher prevalence in Sjogren's syndrome. Also multiple myeloma. Okay? We only have very few symptoms, memorize all, and then always think of these conditions can be under a bigger systemic illness. Is that clear? Question? Any question? What's mononeuritis multiplex? Anyone? What's mononeuritis? We'll be mentioning this every now and then. You know peripheral neuropathy?
It's focal neuropathy.
Yeah. So what's peripheral neuropathy? It's bilateral. Okay? It's uh, both sides of the body. If you have peripheral neuropathy in the lower extremity, then both of them should be involved. So the peripheral neuropathy symptoms are paresthesia, tingling sensation, electric sensation, pin and needles. Okay? It's also burning pain sensation. But for mononeuritis multiplex, it only involves one side or one focal part. If it's just the thigh, then it's just the thigh. If it's just the leg, it's just the leg. And only involves one side. That's mononeuritis multiplex. Otherwise, peripheral neuropathy and mononeuritis multiplex has similar symptoms. Is that clear? Always remember that because in the next meeting, we'll be discussing this. I won't be needing to reiterate that again. Okay? Okay, just read on this one. Lymphoma, it's just the same as the usual lymphoma that you see in hematology. Okay? But lymphoma has a high prevalence in Sjogren syndrome. Okay? At least you know, probably they won't ask you about lymphoma, but this is a cancer that is common in Sjogren's syndrome, then you know it's lymphoma. Okay? So how do you diagnose? Again, as I mentioned earlier, symptoms-wise, you can see these conditions in, you can see xerostomia, Zika, and other symptoms in other conditions. Okay? So you need to rule out everything even before you need to consider Sjogren's syndrome. Also, here are your tests to confirm your Zika and what else? Dry mouth, and also your autoantibodies. And make sure to rule out other systemic autoimmune illnesses such as your rheumatoid arthritis and SLE. If you have those, then probably it's just a secondary Sjogren's syndrome. Anyway, if you treat SLE, if you treat RA, xerostomia and dry eyes will improve. Is that clear?
Yes. Yes po.
Okay.
Yes, Doc.
So, I think everything that has been mentioned in the previous slides are here. So, I think we discussed this. Again, exclude conditions. And these are the conditions you are going to exclude, the one in the orange box or brown box. And then this is just an algorithm on what to do if you are presented with dry eyes and dry mouth. Again, simple. Just do Schirmer's test, cyanometry, just quantify the conditions. Okay? And check for other autoimmune illnesses, and then check for autoantibodies. Any question up to this point? None?
None po.
Okay. So here's the treatment. Again, you aim to relieve the symptoms. You limit the damage from chronic symptoms. Again, what's the chronic symptoms? If you have chronic dry eyes, it will just scratch your conjunctiva, your cornea. I've been saying scratch. I'm so sorry. I just couldn't find the correct term for that. It's in the tip of my tongue, but I can't say it. Okay? Abrasion, sorry. It's abrasion, it's not scratch. Okay? It will cause abrasion of your conjunctiva and your cornea, and it can be a cause of infection, redness, no, for further inflammation. Okay? So we prevent chronic symptoms. So you substitute what is lacking. So if you lack tears, then you use artificial tears, right? But if you lack saliva, do you take artificial saliva? Anyone?
No.
No, you just drink water, okay? Baka maybe you will get saliva from your boyfriend or girlfriend, ha? You just take water. Next is arthritis. If you have arthritis, then treat arthritis. If you have other problems, if you have vaginal dryness, then use topical gels. Okay? And there you go. There are other medications that actually stimulate secretions. However, the dictum, even if you provide stimulation, even if you give medications that stimulate secretion or secretions of these tears or saliva or other mucous secretions, if you're not treating the autoimmune illness, then there's no point of stimulating this secretion. So again, if you treat the autoimmune illness, then you will treat these symptoms. Any question? So
None
what
po.
about lymphoma? If the patient had developed lymphoma, just do chemotherapy, same as how you manage general population. Okay? Any question up to this point for the treatment? Do you know anyone who has keratoconjunctivitis Zika, your xerostomia. None. So, okay. So, usually, the problem with Sjogren's syndrome is that it may really take several years even before you will diagnose this, because the general population would actually tend to think that, when you once you have dry eyes, once you have dry mouth, they thought it's just of the normal daily life. But unless you have other secondary symptoms such as arthritis, then that will actually give you um, higher suspicion of this condition. No? So if you take into consideration just the Zika symptoms, xerostomia symptoms, then that's the problem. It will really take years even before you're going to diagnose this patient. Okay? So any question up to this point?
None po, Doc.
Okay. So we are finished with we are finished with what do you call this? With the um rare connective tissue disease in the form of systemic sclerosis and Sjogren's syndrome. So next week we will discuss mixed connective tissue disease and inflammatory myopathies. Again, for inflammatory myopathies, this is an inflammation of your muscles. Okay, so it's the muscles that are affected. For mixed connective tissue disease, it's an overlap condition of um, several autoimmune illnesses. So always remember that for systemic sclerosis, virtually all organs are affected, but the most common is usually your skin manifestation. Okay? And for Sjogren's, it's on for the mucosa or exocrine glands. Is that any question? Um, can we what do you call this? Can we do a screenshot of our attendance? For a while. Jongwoo, can you do a screenshot? I cannot. Uh, it's not showing. All the participants are not showing on on the entire screen. So how do I do that? How can I see all the members?
I will figure it out po, Doc. Wait lang po.
Because it will only tell me 37 others are here, but I don't know who are present. Or probably, okay, I'll just screenshot the All right, done. I just did a screenshot of the chat box. Okay, are there any more questions?
Not po.
Are we still online next week?
No po. Next week
Ah,
is face-to-face
Face to
po.
face. Okay, see you.
Thank you po.
Bye.
Thank you po, Doc.
Thank you po,
Thank you,
Doc.
Doc.